resident, a couple of years back, we would go to our consultants with interesting MSK, MR, a big mass, and the consultant would look back at us and asking for a plain radiograph, and we would just wouldn't bother because, come on, what's better than an MRI, right? But obviously, time passed. We tried to become a bit wiser, and so one thing you should never comment on any bone lesion without actually having access to a plain radiograph. It's criminal to comment on it. So let's have a look. Now, these are some STIR and T1 weighted sequences. Of course, a lot of you might be exam going. Not every time the examiner needs to tell you the age of the patient, right? You can see on these images, patient is a male, prostate is big, so you know it's an elderly gentleman, and there is a large mass in the left proximal medial thigh. Now, and that mass is invading the underlying pubic bone, right? So again, your list of differentials would include a soft tissue sarcoma secondarily involving the bone, a primary bone sarcoma, although rare but possible, and then of course multiple metastases or multiple myeloma. However, if I show you the plain radiograph, especially in this case, almost every one of you knows the diagnosis. This is a case of Paget's with sarcomatous transformation. How easy it is to actually see it on a plain radiograph. Whereas, of course, in hindsight, you can definitely appreciate the trabecular pattern is definitely altered in the left hemipelvis. But if you're given with a plain radiograph, this is a no-brainer. This is a spot diagnosis. So this was a case of sarcomatous transformation in a patient with Paget's. So, okay, so we have the plain radiograph. Now we have to analyze the plain radiograph, right? But before you go to that point, age is the single most important determinant factor for reaching a list of differential diagnosis for a bone lesion. Even before you start analyzing how does the lesion look, you need to know the age of the patient. That is one most important thing. Now we have this plain radiograph. We have two radiographs. So the one on the left is a young child, 11-year-old. You have an expansile, a little bit expansile, sorry, lucent lesion with a pathological fracture and a fallen fragment sign. On the other hand, on the right side, you have a similar lesion which has some endosteal scalloping, again within the diaphysis of femur with a pathological fracture. Now, if you look at it, on the left, your differential and your diagnosis is a unicameral bone cyst, whereas on the right, it was a pathological fracture through multiple myeloma. Now, Ankita, is my screen still showing? Yeah, that's fine, sorry. So there is no way that you would consider a simple bone cyst in the differential diagnosis of a lesion in a 70-year-old. It just doesn't happen. So even before you start analyzing these bone lesions, you should have a list of differential diagnoses just based on the age of the patient. Again, now there are two radiographs. Once again, quite similar radiology. So on the left, you have this gentleman around 40 years of age with this expansile lucent lesion in the fibular head, which was a giant cell tumor. Whereas on the right, once again, you can appreciate just by looking at the arthritic change in the knee that this is an older individual, and there was a similar expansile lucent lesion, which was a metastasis from renal cell cancer. Again, for a differential diagnosis of a lesion, on the right, you would not consider giant cell tumor as the top of your list because we know it doesn't happen in an age group more of 60 or 70. Now, so we know we have a radiograph and we know the age of the patient. And the third most important thing for us is to recognize the pattern of bone destruction. So a little bit about physics. I'm sure you guys are much more fresher and you have a better knowledge of physics than what I have. But plain radiographs, they do not have the spatial and temporal resolution that MR and CT they have. So what do you see it's an interplay between just five densities on a plain radiograph. So you have air, you have fat, you have soft tissue or fluid, mineral or calcium, and metal. So the image is actually composed, it's an interplay between these five densities based on the difference densities and the interfaces between them. So what do you see on a plain radiograph in a patient with a bone lesion? Do you actually see the bone lesion? On the left, you have a radiograph, and you are seeing it's a typical case of a well defined cartilaginous tumor, likely an enchondroma in the distal femur. And what you are seeing is the mineralization within the tumor. You're not actually seeing the cartilage lobules that aren't mineralized. You are literally just seeing the added density, which is the matrix or the mineralized bit of the tumor. Normally, what you see is a situation like that on the right, where there is this permeative pattern of bone destruction in the distal femur. You have this interrupted periosteal reaction, a cortical breach, and the extraosseous soft tissue mass. So on a plain radiograph, you see either the tumor, if and only if the matrix is mineralized. Normally, you see what the tumor is doing to the parent bone. What is the rapidity of destruction of the parent bone, and how the parent or the host bone is responding? That is generally seen in kind of, with the specific patterns of periosteal reaction. So you don't see a bone tumor unless at least 30 to 50% of the trabecular bone is destroyed, because you actually are not seeing the tumor, you're seeing the destruction of the trabecular bone. So when you analyze a radiograph, what do you call it? Do you call it benign or malignant? Do you call it pattern of bone destruction? Again, benign or malignant is not a radiological diagnosis. Of course, I can say that this lesion looks malignant, but I am not a pathologist. Let them do their job, right? Uh, you don't know how much what's the nucleus like, what mitotic figures there are. So you can't comment on that. What you can comment on is, does it look malignant? Does it look aggressive or non-aggressive? So it is, of course, common sense, right? Most malignant lesions, these are nasty lesions, and of course, they're sinister. They would appear aggressive on a plain radiograph, and most benign lesions would be non-aggressive. That's common sense, but that's not rule of the land. This is not always the case. So on the right, we have again an immature skeleton, a 6-year-old kid who presented with this ill-defined bone destruction. You can see it's not geographic. It's not really well defined. If I tell you, you cannot with a pencil tell me the normal from the abnormal bone. So the pattern of destruction, it is a bit permeative. And we have this multilamellated periosteal reaction. It's involving the diaphysis. So the differentials would include, yes, Ewing sarcoma, a round blue cell tumor. It can be infection, or it can be eosinophilic granuloma. And in that case, this was eosinophilic granuloma. And as you can appreciate, there's a radiograph after 8 months when you can see the lesion is consolidated, the periosteal reaction is all now, it's all dense and completely solid. On the other hand, again, an elderly person with a bone lesion in these subtrochanteric location doesn't look overtly aggressive. The pattern of bone destruction isn't really bad, doesn't look nasty, but this was a biopsy proven multiple myeloma. So always be careful about the terminology that you use. Now, this slide is something that you all are familiar with. This is something you all know. What classifies as an aggressive lesion is when your pathological process is so aggressive, so fast. It's just destroying the bone. So you don't have a well-defined margin between your normal and an abnormal bone. Now we talk about the zone of transition. So when your pathological process, which can be infection, which can be anything underlying inflammatory or a tumor or infiltration, when that process is so rapid and fast that there is no time for the host bone to contain your pathological process. So you cannot draw the margins between the normal and abnormal bone. So that means the zone of transition is wide. Now, interestingly, periosteal reaction. Now, always keep in mind, Periosteal reaction is pathological. I'm not saying it's malignant, but it's pathological. It doesn't happen one day on a Sunday, your bone suddenly decides, oh, hang on, I need a new periosteum. It doesn't happen like that. Your body does not lay new bone just like that. Obviously, there has to be an inciting factor, some trigger. Now that can be a marathon you ran on a Saturday. So, you have stress. That can be infection, an actual trauma resulting in fracture, inflammation, anything infiltrating your bone marrow or a bone tumor. But whenever you see periosteal reaction, you have to investigate it further because it just doesn't happen on its own. And of course, you can see cortical destruction and soft tissue involvement when the lesions are aggressive. Now this is a typical textbook case. There is an ill-defined sclerotic lesion, distal femur, a multilamellated periosteal reaction, which is interrupted, having a Codman's triangle, some amount of perpendicular, some osteoid formation, and an extraosseous component. Now this is osteosarcoma, right? The top of the differential list, you have osteosarcoma. Now, mostly you don't really have your bone tumors haven't really read our books, right? They don't always present with all these 5 findings. You have to look for subtle findings. Now, another patient, now this is just for 1 second, look at the periosteal reaction in this case. It's really very solid. It's like a block. It's unilamellated, very solid, versus what you see here. A really aggressive periosteal reaction. So, looking at this periosteal reaction, this is something slow growing. This is not a really, really aggressive pathology. Of course, there's a pathology, but it doesn't look aggressive. And on the frontal projection, a just tiny lucent lesion there. Of course, if I give you the history in this case, everybody knows the diagnosis. Patient had night pains, relieved by salicylates, and on CT, you can see the nidus. So, um, obviously, we'll discuss it later, but CT is really, really good, and it's even better than MRI in patients of osteoid osteoma. Now, again, this is what I was trying to tell you about previously. So there's this lucent lesion in the distal femoral metaphysis. Now, interestingly, there's no pathological fracture, but posteriorly there is periosteal reaction. So your periosteum is responding. Also, it does look quite well defined, definitely caudally, but on the frontal projection, especially the cranial margin, it isn't really sharply defined. So this actually was misdiagnosed as aneurysmal bone cyst, whereas indeed it was on biopsy, it turned out to be an osteosarcoma. So again, you don't see a large extraosseous mass, you're not seeing a Codman's triangle, you're not seeing osteoid, but you see that this pathological process is active. It is causing periosteal reaction. It doesn't have a very narrow zone of transition in the cranial aspect. So always investigate further. Do not be afraid of doing biopsies. When you're in doubt, just put a needle and just prove, either you'll be right or you'll be wrong. There's only 2 options, very binary. Now, even if you are an MSK radiologist or you're not, but I'm sure we all report a lot of knee x-rays and hip x-rays. They are the boring bits of your reporting piles. 99% is just going to be osteoarthritis, right? But 1% you will find something or you'll miss something very important, like in this case. So this lady, really nice lady, presented in December to the GP with excruciating knee pain. Did a plain radiograph. Again, radiograph was reported just osteoarthritis. But if you look carefully, especially at the lateral distal femur, there is a periosteal reaction, right? And on the lateral aspect, so the cortex is fine, smooth. And just about here, there is irregularity and some added soft tissue here in the suprapatellar space. Now, again, this was reported just as osteoarthritis. Patient came back after 4 months with excruciatingly painful knee and swollen leg. Of course, now you see the trabecular pattern is definitely altered. There is ill-defined sclerosis with a very wide zone of transition in the distal femur. Periosteal reaction is much, much more apparent. There is osteoid or mineralization in the extraosseous soft tissue, which is best seen on the lateral projection as well. And we biopsy this, and this was an undifferentiated bone sarcoma. So always be very, very careful, especially when at the end of the day, when you're just reporting a plain radiograph, especially knees, mostly it would be osteoarthritis, but every once in a while, you might actually find something that can be life-saving. Now, this is another such example. Clinical history, right hip pain, and it was reported minimal degeneration, right hip, joint spaces preserved, blah, blah, blah. Cardinal rule of radiographs when first year, when we are taught plain radiographs, always look at the corners, right? That corner is fine, but look what's happening here in the bottom left corner. Where's the medial cortex of femur? You can't really see, just compare it with the right. You can't really see. There is this ill-defined infiltration going on there with cortical destruction. And this indeed was a large expansile deposit from renal cell cancer. Patient was in pain because of the deposit, not because of arthritis. Mostly, again, you can reach a list of differential diagnosis by localizing the tumor to epiphysis, metaphysis, or diaphysis. Most of the tumors are localized to the metaphysis because your metaphyseal region is the region of highest cell turnover. Of course, wherever there is more turnover, there is a high likelihood of genetic mutations. Hence, more lesions are noted here. Also, one point to note, which we discussed previously, there are only 5 densities. So what happens is you only see a tumor when 30 to 50% of trabecular bone is destroyed. Your trabecular density is highest at the epiphysis and the metaphysis. So a lesion in these area, in these two locations, is better seen and seen earlier as compared to diaphysis, because in the diaphysis your trabeculae are sparse. So you need to have more destruction in order for the contrast or in order for the differential density. So lesions in diaphysis are diagnosed later just because you just can't see the contrast between the destroyed trabeculae and the normal surrounding trabeculae. So we have a plain radiograph, we know the age, 12-year-old boy, and we have an epiphyseal lesion. Now, the list of differentials for a lesion in the epiphysis are really rare, right? It can be chondroblastoma, infection, Brody's, and this, in fact, was a case of infection. You have the penumbra sign and exuberance surrounding bone marrow edema. So just even if you do not look on the plain radiograph and you know that it's a 12-year-old boy with an epiphyseal lesion, if you do not even characterize the or try to look at the pattern, you know the differentials are going to be one of 3 or 4. So another lesion, 40-year-old female, there is an expansile eccentric lesion with a pathological fracture reaching right up to the subarticular location with a large hematorosis. This, the top of your list of differential diagnosis, would be a giant cell tumor, right? Because that just fits with the radiology, age group, and the appearance. Now, this lesion is literally similar, except it's centric. But other than that, it's exactly similar to what you saw just previously. So that's your 40-year-old. This is your 60-year-old female. A multiloculated lucent lesion has a narrow zone of transition. So when I recognize the pattern of bone destruction, I'm not overtly concerned because this doesn't look aggressive. It is very well contained, having a narrow zone of transition. And we do a CT and an MRI. And on the CT, you can see the discontinuation of the overlying subchondral bone. So this was not giant cell tumor. In fact, this was a large intraosseous cyst or geode. We discussed it in the MDT and we didn't really do biopsy. There's no need for them. You can just simply ignore these lesions. Of course, we've talked a lot about how important a plain radiograph is. I'm not negating the importance or value of CT or MRI. The MRI is the best imaging modality after you have recognized the pattern of bone destruction. You have to do an MRI because you see the matrix, you see the extent of the tumor. It's really important for biopsy planning. It's really important for our surgical colleagues to plan resection or treatment. So MR is really, and it also narrows your list of differential diagnosis. You can look at skip lesions or METs or, and also for looking for response to chemotherapy. Now, again, this is a classical case. There is this Lesion lesion in the calcaneum, very non-aggressive. I'm not worried about it, but it can be a cyst or a lipoma. You cannot tell that on a plain radiograph, right? You do an MRI and you know it's a it's a simple bone cyst within the calcaneum. Exact similar radiology. Again, a non-aggressive lesion, Lesion lesion in the calcaneum could be lipoma or cyst. Of course, the only thing that can give an answer for this is either an MR or a CT. And on MR, you can actually see that this has fat signal. So this is an intraosseous lipoma. Now, we have our surgeons really, they're experts in doing revision, rehips and knees. So we see a lot of this. Patient had a hip replacement, complex left hip replacement, presented with pain and swelling. And on the plain radiograph, you can appreciate this really large, expansile, multiloculated, multiseptated lesion. Cortical breach, definitely on the lateral aspect. There is no cortex laterally, and also some acetabular loosening. Now, again, you recognize the pattern, you recognize the bone lesion. It can be a lot of things, right? Uh, and once you do an MRI, you know this is not a malignant process. This is not a metastasis. This is not a primary bone sarcoma. And you know it how? Because you look at the signal on the MRI. So you have T1, you have your STIR and your PD sequence. You can appreciate that this lesion kind of has a very thick, well-defined low signal fibrocapsule, and the signal intensity on the fluid sensitive sequence is really dirty, it's really low. So this is actually a pseudo tumor. This is a wear and tear response or to the metallic debris or a lot of, the implant basically. This was a granulomatous response to the underlying implant. This wasn't a tumoral process. Now, if you see a newborn lesion in an adult more than 40, you should consider it malignant unless you prove it otherwise. I'm not saying they are malignant. And of course, it's difficult because we do not have historic imaging, but you should always have an open mind because a simple bone cyst is not going to form in an adult. You're not going to suddenly get a fibrous cortical defect in an adult, right? If you have historic imaging, of course, well and good, you can compare this lesion was present for a long time. But if you don't have historic imaging and this is the first time your patient presents to you with a bone lesion, do a proper workup. Do not just assume that to be benign. And always include metastasis and multiple myeloma in the differential diagnosis of a bone lesion in an adult. And do ask for a chest radiograph. Trust me, it will save you sometimes the embarrassment in front of your pathology colleagues. Um, Now, this was such a case that came to us actually. So their patient had pain. We did a radiograph, and on the radiograph, as you can appreciate, there is a lesion in the left greater trochanter, which has a wide zone of transition and looks aggressive with loss of cortex on the lateral aspect. Now, did an MRI, and on the MRI, this looks like a large deposit. The only confounding factor in this case was we were told that the bloods are a little bit normal. There were some abnormal light chains on the myeloma screen, not definitive, but some light chains were seen. So in our mind, of course, we had a bias that this can be plasmacytoma. Patient had a bone scan, and on the bone scan, this was cold again, which was like, oh, it does go with plasmacytoma or multiple myeloma. There was no uptake on the bone scan, and we proceeded with a CT guided biopsy of this lesion. And obviously, all our biopsies we discuss in our multidisciplinary meeting. That's on a Thursday, and when this was being discussed, our pathologist asked for a chest radiograph, and I have to be honest, we didn't really have one. And we did a CT after that. This was a case of bronchogenic carcinoma with metastasis to the left greater trochanter. Now, your metastasis can be solitary. Obviously, generally you see multiple deposits, but you can get solitary mets from bronchogenic cancer. Kidney is really notorious. Around 7% of renal cell cancer metastasis would be solitary. So be very careful and always obtain a radiograph. Generally, when our working diagnosis, we have mets as one of the differentials, and that's really high up in the list. we do a CT chest abdo-pelvis staging for all patients. I do understand that's not possible in all your centers, depending on different centers you're working, but always keep an open mind because any bone lesion can be metastasis in somebody who's older. Now, if you see a bone lesion and patient is a known case of malignancy, you still have to biopsy that. Now, this is really important because this will catch you out. Now, it's a knee-jerk reaction, right? Patient has a known cancer and patient has a bone lesion. What else could it be? What are the chances of it being something else? They're really rare. Statistically, you're right. Metastasis is 30 times more common. It's really rare for somebody to have two different primaries, but it's not unknown. So clinically, it's not a safe practice. So whenever even if we have a patient with a known malignancy, and he presents with a solitary lesion, we do always needle that lesion. Sometimes we even needle multiple mets because there have been cases where patient had multiple myeloma and breast cancer. So you need to know the bone lesions are metastatic breast or are they multiple myelomatous deposits. Now, this was a case of esophageal cancer, had PET CT as a part of staging. And of course, you can see this uptake in the distal esophagus, and there was uptake in the right acetabulum as well. So we did an MRI, and on the MRI scan, there is a deposit in the right acetabular roof. So you can definitely see there is a definite deposit. Um, we did a CT biopsy. Our working diagnosis definitely was an esophageal cancer with a bone metastasis. However, biopsy, this turned out to be a low-grade chondrosarcoma. So see, in this case, your biopsy really changed the management. So whenever you're in doubt, or you think that your radiological opinion can literally change the entire management, can change the prognosis of a patient, just go ahead and put a needle in. You will not regret biopsying a bone lesion, but trust me, you will regret not putting in a needle. Now, there was another case. This patient was a case of prostate cancer, had a bone scan as a part of staging. And on that bone scan, you can appreciate that there was this increased uptake in the proximal tibia on the left. So, of course, we evaluated it further, had a plain radiograph. And on the plain radiograph, there is this well-defined sclerotic, faintly sclerotic lesion in the tibial diaphysis. Further did cross-sectional imaging. Again, it does have a ground glass matrix. It does not look concerning. Even on the plain radiograph, the pattern wasn't aggressive. It looks like a quiet quiescent lesion. And on MR, the surrounding bone marrow is completely unremarkable as well. So we were not concerned. If this patient did not have history of cancer, we would probably follow this case rather than putting in a needle. But now, just in case, this turns out to be metastasis, your management changes completely. So we did put a needle in this, and as we had our working diagnosis, this was a case of fibrous dysplasia. We just did not have previous imaging. If we had previous imaging, we would not have put a needle in it. Okay, now this is a contradiction to what I have been trying to say. Obviously, you have to have an open mind when you are dealing with bone lesions. Mets myeloma are always in the differential, but also have a really open mind. Not all bone lesions are tumors as well. There are tumor mimics because what we discussed is you don't see the bone lesion, you just see what the underlying pathology is doing to the bone. So it can be something non-malignant or non-tumorous. Like this patient presented to us, a 40-year-old presented to us with pain and swelling in the proximal forearm. Frontal projection looks all right, nothing much. However, on the lateral projection, there is this new bone formation, right? There is a periosteal reaction, which doesn't look worrying, but I can't see any underlying bone destruction. I can't see. The trabecular pattern looks all right. Now, there can be a lot of differentials for this. And also just see the displaced fat plane, as we said. So there is space occupation. There is something displacing the fat plane and something causing the bone to react and form this new periosteum. differentials can be broad, it can be wide. And so we did an MRI. And on the MRI, I'm sorry, the images aren't really great in this one, but just see, there is the abnormality centered at the radial tuberosity. You have the distal biceps tendon, which is really, really thickened, and there is a lot of fluid. There's a lot of inflammation in the bicipitoradial bursa. And all this on the sagittals is your new bone formation. So this was a case of bicipitoradial bursitis, secondarily resulting in this pressure effect and this chronic pressure effect on the anterior cortex at the level of radial tuberosity, resulting it to form bone. So not all bone lesions, not all periosteal reactions are due to a primary bone pathology. It can be a pressure effect from the outside. Again, this was, as I said, we are a bone sarcoma center. So any bone lesion, they just refer to us, sometimes even without looking at the imaging. So this patient was a known case of tumor, had breast cancer, presented to us with this, was referred to us with this lesion. They were suspecting Mets. Now this does not look metastatic. You know, you have a very well-defined lesion, has a very narrow zone of transition, really small, adjacent to the intercondylar notch. And we did an MRI, and of course, you can appreciate this is just another case of intraosseous cyst or a small geode at the site of insertion of the cruciate ligament. So again, discharge the patient. There's no need to put a needle in such a case. And also, never forget tumor mimics. As we discussed previously, there is only a finite number of ways your bone will respond. You know, your host bone has a problem. Now that can be tumor, that can be infection, that can be anything, and there's only certain ways it's going to respond. So you will get a lot of tumor mimics, which can actually mimic tumors, which can be traumatic. You can have infection, you can have inflammatory diseases, and so on. So again, it's a spotter, a typical case where you have a problem in the medial end of clavicle. You have a lot of cortical hyperostosis, uh, replacement of the bone marrow fat, and this complete new bone formation, completely enveloping the medial clavicle, also appreciated on CT with multiple lucencies. You know, this is a case of CRMO. You have multiple multiloculated cystic lesions in Brown's tumor or hyperparathyroidism. And another important thing now is always liaise with your team. As I said, we have a multidisciplinary team where we have the radiologists, pathologists, the surgeons, the oncologists, the radiation guys, and we all discuss. So we plan the biopsy together, we discuss the results together, and we discuss what we think versus what the pathologists think. Um, if you work in such a center, it's amazing that's the best way to learn. I've learned so much from my surgical colleagues in the last 5 years. If you work in standalone centers or you don't have such a team work in your hospital, please just pick up the phone and call. You know, make friends, talk. You will not regret it. You will develop a rapport with these people. You will learn your radiology practice, which benefit much, much more by talking to your surgical colleagues and your pathologists than actually, reading books or, other things. So this was a case we saw last year. In March, patient was admitted in the ICU and had a chest radiograph. And you can see, again, chest radiograph is something you can never get rid of. Even if you're an MSK person, you have to be the best at reading a chest radiograph. You're going to do this all your life. So again, there was this expansile lesion involving the anterior end of the right sixth rib. So that was March. And you have another radiograph in September. Now, there is a definite increase between March and September in that lesion. A CT was done, and on the CT, you can see that the anterior end of the right sixth rib is destroyed. The bone is permeated. You have the cortex that is thinned and breached, and there's a large extraosseous soft tissue component. And again, this altered pattern of bone here. So it is at the costochondral junction. We were really concerned, and we thought this is a chondrosarcoma. The MR just shows you, the large extraosseous soft tissue component in great detail. And we biopsied that, and on the biopsy, the pathologist said this is a low-grade chondroid lesion, no evidence of malignancy. Now, there is a definite discrepancy. On imaging, this is aggressive. On imaging, this is a chondrosarcoma, no matter what the pathologists say. So we discussed in the meeting and we were like, we're not happy with your diagnosis. Of course, there are a lot of issues with sampling. Again, I don't want to, we can't go into detail with them, but that'll also take time. So we were really, really concerned with the imaging of this patient, and the surgeons went in and resected, and this was grade 2 chondrosarcoma. So always, if you think that it's not correlating pathologically, rebiopsy or just follow it up, but just you do not just let it go, because you're seeing the lesion, this looks nasty. It can't just be a simple chondroid lesion. And the last is, if your clinical behavior is atypical, always investigate. Again, we are just seeing these static images. At the end of beyond that static image, there is a patient. And if that patient has symptoms, no matter what your imaging shows, you have to investigate those symptoms. You have to follow it up. You have to put a needle, because you have to investigate the symptomatology, right? So if your patient has new symptoms or the symptoms are increasing, you don't think this is anything malignant, you don't think this is anything aggressive, but the patient or your surgeon comes back saying, the patient's symptoms are increasing, please do not hesitate to revisit your diagnosis. It's okay to be wrong. I'm sure we all commit mistakes. So, but the best thing is to appreciate it, have an open mind, work with your surgical colleagues, find alternate cause, and if you can't find an alternate cause for the pain, then go in and needle that lesion. So either you can follow it up or you can do biopsy. And always, always, pain is a big red flag. So if there is pain with a bone tumor, it can affect your decision to biopsy. Like, we don't think this looks aggressive, but patient had unremitting pain. The pain's just not going. Just put in a needle and just prove what you think it is. So yeah, it is pretty simple. The concept of no touch lesion, we don't really follow that. So even if we have a patient who has a simple bone cyst, Bangalore, simple bone cyst, fallen fragment sign, there is no other differential. We still follow these patients up. So we are in contact with the patient. We follow them up a yearly or probably after 2 years, just a radiograph to see if they are healing well. It's consolidating. But so the no touch is probably wait and see. See how the lesion or the patient is performing before you just kind of discharge the patient from your care. So this was a case of 39-year-old female. There was a lesion in the greater trochanter. Now, this is a very well-defined lesion. There are no concerning radiological features, geographic margin, well-defined. I'm not concerned, and has a matrix as well. We were following this lesion up from 2017 as a chondroid lesion. However, patient kept having pain. And on the MR, again, it was completely unremarkable. There was no trochanteric bursitis. The hip joint was unremarkable. So there was no alternate cause that we could find what could be causing the pain. And generally, we do not biopsy them unless they look worrying. This wasn't looking worrying. This was stable. But the only thing that prompted us to put a needle in this case was pain, and we biopsied this, and this was another case of grade 2 chondrosarcoma. So always go by the patient's symptoms. Now, there are just a few interesting cases of something that we see, and something that I thought it's interesting to share with you. So I have 3 cases, and probably that's the end of this talk. So this was an 85-year-old woman who presented to us with unremitting back pain for 2 months. She had constitutional symptoms of loss of appetite and weight loss. CRP was a bit elevated. CEA was 7.4, a bit high. We did a whole spine and a pelvis MR. So on the whole spine, especially on the stir sequences, you can see that there are multiple lesions which are diffusely distributed in the spine. There are some lesions in the posterior elements as well. We have a pathological collapse here. And on CT, all these lesions, you can see about this faint sclerosis within the sternum. These lesions within the pelvis are also vaguely sclerotic. Similarly, faint sclerosis was also appreciated in the lesions within the spine. So again, just an MRI of the pelvis showing you the extent of the abnormality. So it was quite diffuse, the abnormality. You have a lot of abnormality in the eye leg blades posteriorly. You can see on stir sequences, they were high. And we decided to biopsy and we chose the right posterior eye leg bone. You can see the needle went right through the area of trabecular sclerosis. It was biopsied, and the biopsy again showed chronically inflamed and remodeled bone, no evidence of tumor. But again, if you look back at our imaging, we are definitely concerned. There is something going on. We don't know what, but she's elderly, she has constitutional symptoms, and she has these faint sclerotic lesions everywhere. So, what we decided to do next, which is a standard practice when we in a patient when we have such diffusely distributed vaguely sclerotic lesions and the biopsy comes negative, we ask for a PET. So we did a PET scan and see, interestingly, the PET is quite understated as compared to what you saw on the MRI. So the vertebral bodies do not have much uptake. The right posterior iliac bone, interestingly, which we targeted for biopsy, does not show PET uptake, but there was a big area of avid PET uptake in the right anterior superior iliac spine and some areas of uptake on the left hemipelvis as well. So we decided to go for a repeat biopsy, and in this case, we chose the site of biopsy depending on our PET. So on the PET avid area, which was the anterior superior iliac spine, we biopsied that, and that showed lymphoma. So the takeaway from this is whenever there's a discrepancy between your functional and conventional imaging, always think lymphoma. When you think your PET is understating, when you think that, oh, there are some lesions, and lymphoma has a tendency to sweep through the skeleton. There can be a lesion which is very avid, and by the time patient gets a biopsy, it just becomes non-avid. So we for especially when we have a non-diagnostic sample and we really think that this could be lymphoma, we use PET to target a site for biopsy, and we target the most PET avid site for biopsy. So always be careful if you have sclerotic lesions with repetitive negative or non-diagnostic biopsies. Do not just forget about it. You've biopsied, you've done your best. I don't know what it is, but there is a pathological process. So follow it up, and one way you can actually keep following it is by doing a PET, finding the PET avid area, and then needling that area. Now, this another case, our second case, was a 24-year-old woman who had fibromyalgia and came with right-sided chest wall pain. And she had a really long history. She said that the pain's been there for, 10 years or more than 10 years. Clinically, the impression was costochondritis or thoracic nerve entrapment, and the biochemistry was completely normal. Now, these are the far lateral parasagittal images, and you see there is an abnormality, right? Something is not quite right, centered at the costovertebral joint, and there's a lot of stir signal hyperintensity, there's a lot of edema. So generally, when you're reporting your spine scans, uh, go go to the far lateral and always look at the costotransverse and your costovertebral joints. Normally, if you have involvement of those joints, you can see involvement of those joints in cases of spondyloarthropathy. Sometimes that's the only clue. Everything is normal, but your costotransverse joint is eroded. So that's a case of ankylosing spondylitis or non-rheumatoid inflammatory spondyloarthropathy. So in this case, if you look at the further magnified images, so you have the T1 and T2. So just look at the cortex of this bone. That's not quite right. There aren't erosions, but the cortex is it's really thickened. And once again, there is hyperintensity on the T2 weighted sequences, and this ovoid focus of low signal. Again, just showing on the axial images, the abnormality. So you have an abnormality at the tip of the transverse process, and you have a lot of edema in the transverse process. Now, the costotransverse joint itself is normal. So we're not thinking this is anything inflammatory because there is no erosion. The joint itself is normal. There is just some abnormality at the tip. Now we don't know until this point we didn't really know what it could be. And we asked for a CT to see if we can actually appreciate the trabecular pattern better. Now we have this CT, and again, just look at the periosteal reaction. So there is this exuberant new bone formation on the undersurface of the bone. Again, so you see, there is abnormality. So it's a closed space, right? The intercostal space is really narrow. It's a closed space. There is something happening which is resulting in this new bone formation on the rib on two opposing ends of the rib. You see this new bone, you see this new bone formation at the cranial border and the caudal border of two ribs, which are close together in a closed space. Just a sagittal scan to actually appreciate. Now, when you see such new bone formation, a young patient, there's one thing you should always consider, and this was a case of osteosteoma. You can just about, of course, on this CT, you can see this tiny, tiny leucine lesion in the tip of the transverse process, and that has this focus of mineralization. So this was an osteosteoma. It was proven, and then it was done cryoablated for. So the key takeaway in this one is osteosteomas can actually present with a very long protracted history. Your imaging is mostly responsive. What you see, so that's why for osteoid osteomas, your CT is really better than MRI because you have so much of response, you have so much of prostaglandin production, you have so much of inflammation there that on the MR, that bone marrow edema will actually mask that nidus, which is best seen on CT, and always have a multimodality approach. Now, this is the last case. So we think we know it all. We know how to recognize. We have the pattern recognition. But every once in a while, you'll be taken by surprise. So this was such a case that presented to our hospital. So this was 2014. This patient was 14-year-old, presented with this lesion and had a pathological fracture. Again, uh, multiloculate, a lucent lesion has a narrow zone of transition, a typical fallen fragment sign. So my top differential is a simple bone cyst. That was the working diagnosis. However, patient kept having pain. Pain settled, but she had a history of paresthesia and she presented again. So this was December 2015. So in December 2015, when, as we said, we do not discharge these patients if they have pain or symptoms that are recurrent or symptoms that are not responding, we call them back. So she presented again in December 2015. And as you can see now, that lesion looks healed. There is consolidation of the lesion. Again, there was no cortical breach, there was no periosteal reaction, and once again, it looked quite quiescent. It looked like a lesion that's just sitting there. So that was December 2015, and we did an MRI as well at this point, which once again shows this sharply demarcated and marginated lesion, space occupying lesion, T1 hypointense. Again, the surrounding marrow was completely unremarkable. There was some expansion, but the periosteum was completely normal. No periosteal edema, no periosteal reaction. So in December 2015, this was her MRI. And this is what happens in March 2016. So the tumor is gone, it's gone crazy. There is no, you don't have to tell me what this is. This is completely, the tumor gone berserk. This is a very aggressive, destructive process, which has completely eaten up the proximal humerus involving the humeral head, neck, and the proximal diaphysis with this permeative pattern of bone destruction. On the MR, again, you can appreciate the large extraosseous component, multi-compartment, multi-septated, and you have these multiple fluid levels. So you know that the working differential diagnosis for this case was a telangiectatic osteosarcoma. It was proved to be a telangiectatic osteosarcoma, and they did an endoprosthetic replacement. So a patient was operated upon, and again, this tumor was absolutely nasty. It came back with a vengeance. Now, this is post operative imaging. You can see massive, massive recurrence, even extending along the subclavian vessels up to the base of neck, root of neck, and patient expired a couple of months after. So, again, you think you know it all, you try to follow a pattern, but every now and then we still don't know. We have looked at this case multiple times where we could have intervened first because it just happened in such quick progression. So take home point, that was the last slide. Take home points is, if anything, you just need to remember these four things. If you forget everything else I showed, your radiograph is the most valuable for evaluation of a bone tumor or assessment of a bone tumor. Your age is the single most important determinant factor to reach a list of differential diagnosis. It's not your job to actually give the diagnosis, right? That's the job of the pathologist. Your job is to actually come up with sensible two or three, a short list of sensible differential diagnoses. And always be careful about the patient's symptoms. Do not discharge away these patients. If they're complaining of pain, call them back, do a repeat imaging, put a needle in, confirm the diagnosis. Yeah. And presence of pain should always be investigated. That's it. We done.
Thank you so much, Simran, for such an amazing talk and actually covering up what is really important, which we should focus on. Can you just have a look at the Q&A section once? It has
Where
quite a lot of case-based QA. So if we can go through few of them at least.
I sorry, Ankita, I thought I overran, so I didn't bring extra cases.
No, not extra cases.
Okay,
So
okay.
the cases which you have shown, just